My name is Amy Killelea, and I'm Assistant Research Professor at Georgetown Center on Health Insurance Reforms. And I want to welcome all of you to our latest webinar in a series of webinars from CHIR on advancing diabetes coverage and access in the private insurance market. So for those of you who are new to the Center on Health Insurance Reforms, I want to give you a little bit of background about who we are. So if we'll advance to our next slide, there we are. We are a nationally recognized team of health insurance experts within Georgetown University's McCourt School of Public Policy. We conduct legal and policy research and analysis. We publish reports and provide technical assistance to stakeholders and policymakers across the country, both at the federal and state levels. We have teamed up with the Leona M. and Harry B. Helmsley Charitable Trust to apply our passion, enthusiasm for private insurance to better understand the issues facing patients with diabetes who require insulin and the reforms that could improve coverage for them. So as part of that effort, we are focusing today's webinar on the relationship between clinical standards of care for diabetes and payer coverage policies for diabetes devices, medications, and services. We've released a blog post on this topic earlier this week, so we'll drop that in the chat for folks. Please take a look, have a read. And I'll also take this opportunity to plug our next webinar in this series, because many of the topics that you hear about today will actually set us up to have a deeper conversation on December 16th at 1 p.m. Eastern, where we'll be releasing CHIR's research on continuous glucose monitor private insurance coverage, where we'll be talking about our findings from an in-depth analysis of plan coverage documents. So watch this space. December 16th is basically a continuation of what I think will be a really interesting conversation today. So before we get started into the sort of the meat of our webinar, I want to go through a few housekeeping matters. So first, we are recording the webinar today. We'll share the link with everyone as per usual. And if you like what you hear today, share the recording with others in your network to help us get the word out. It'll be up on our website as well. Second, the chat is open. Say hi, flag any technical issues you might be having, and we'll try to address those. Keep an eye on the chat too. We'll be using that to post links to a few resources as we go during the discussion. And last, we have built in plenty of time to take your questions. If you've been with us before, you know we sort of have a fireside chat type of vibe to these webinars. We really want a robust discussion and an engaging format. So please feel free to submit your questions as we go in the Q&A button. That's right there at the bottom of your Zoom screen. And then know that we'll be devoting time to take your questions and pose them to our panelists towards the end. So I also want to invite our speakers. We've got three amazing speakers with us here today. You're going to hear lots of perspectives from them a bit later. Kyle Banks, welcome. Kyle is the founder of Kyler Cares Foundation, a nonprofit focused on improving health outcomes for people of color living with diabetes. Kyle established the foundation after being diagnosed with type 1 diabetes while performing in the Broadway musical The Lion King, and then experiencing firsthand the scarcity of information about T1D in communities of color. We're super excited to have Kyle here. Next, we have Dr. Osagi Ebekosian, who many of you know from the ADA. He serves as the Chief Quality Officer at the American Diabetes Association, where he leads efforts to integrate the ADA's standards of care into routine clinical practice with a focus on quality primary care and access. He works with his team to ensure that diabetes care is guided by the best available evidence. And finally, we have Heather Foster, who is the Vice President for Marketplace Policy at the Association for Community Affiliated Plans, which represents about 85 not-for-profit safety net health plans, which collectively provide health coverage to more than 30 million people, and 31 plans in the individual market covering over 2 million people. Heather leads the association's policy and advocacy efforts to ensure people enrolled in ACA marketplace plans have access to affordable quality care. Welcome to you all. We're glad that you're here with us. So I am going to provide a little bit of a foundation before we get into the in-depth conversation and Q&A with our panelists. So I'm going to introduce us to some of the terminology you'll hear throughout the webinar, and then I'll be asking our speakers to provide their perspectives on how clinical guidelines and evidence inform coverage decisions. And ultimately, because I think the ultimate goal here is how people living with insulin-requiring diabetes are impacted by these decisions. All right. Let's start with getting our heads around the terminology that we'll use when we talk about insurance coverage for diabetes medication services and devices. Insurance plans use what's called utilization management techniques to ensure that individuals get safe, effective, and cost-effective care. Prior authorization is probably the most widely used utilization management technique, and that's where a provider has to get a plan's prior approval before the plan will agree to cover a particular service. So in this case, a provider may submit information to the plan demonstrating why the service is medically necessary. In other words, why is it clinically necessary for the care of the patient? And why a particular service, or if we're talking about diabetes, a particular device, for instance, is needed instead of an alternative. So to sort of put a little bit context of this in the diabetes space, some examples that we see, and this is a little bit foreshadowing some of our CGM research that we'll talk about on December 16th. But for instance, for CGMs, a plan may put a prior authorization on a certain CGM device and then require a patient to demonstrate why they need that particular device, so that particular CGM, over a different CGM that perhaps is a cheaper CGM. And the other example where this may come up in the CGM space, a plan may require a patient to demonstrate that they're having trouble achieving glycemic targets before the plan will agree to cover any CGM. So those are two examples of how a specific clinical criteria can be applied to a device, and prior authorization is sort of the mechanism that the plan is using to review whether the patient meets that criteria or not. And utilization management becomes a way that plans really try to balance sort of two competing goals, right? Which is controlling costs, which ultimately keep plan premiums down, and ensuring that patients have access to safe and effective services. And sometimes, and I'll just sort of foreshadow, right? There's tension points between balancing those two goals. So next, let's talk about how plans ultimately are making decisions about coverage. And I want to use sort of prior authorization as our example here and basically peek under the hood at how plans are making decisions about what limitations are appropriate to place on diabetes services using prior authorization. So we have this graphic. It may look familiar to you if you've been on this journey with us from the beginning. It depicts a prior authorization process. You've got the provider and the patient there on the far left. And the provider is going to make a recommendation for an intervention. Maybe it's for a particular CGM, maybe it's for a particular AID, based on that provider's clinical judgment for the patient in front of them. And so let's say that that CGM or AID has a prior authorization. The plan has put a prior authorization on it, which, as we discussed, means the provider is going to have to explain to the plan why the patient needs that particular CGM or AID instead of a different one. And the plan is then going to review whatever information, including medical records and justification, that the provider sends. And the plan is going to make a decision. They're going to approve that coverage, say, yes, we agree with the provider and the evidence they provided, or they're going to say, no, you have not met our criteria. But let's zero in on how the plan is making that decision. The plan typically has a coverage policy. So we've zeroed in on this sort of document icon. So look at that. It's deceptively small, but it carries a punch. And the coverage criteria that a plan has is going to set out the criteria a patient has to meet for access for coverage of a certain service. That coverage criteria might take into account clinical guidelines like those developed and published by the ADA, which we'll hear Dr. Asagi talk about in a little bit. And it might also take into account cost, which could include the underlying price of the device as compared to prices of other device, and then any cost savings access to the device might yield to the plan. So a whole lot of different considerations go into that coverage policy, but that's the rules of the road, right? That's the policy that the provider on behalf of the patient is going to use to justify access to a particular service. So finally, before I turn it over to our speakers, how did the standards of care kind of come into coverage decisions? Clinical guidelines like those that are developed and published by medical societies often inform a plan coverage policy, and because they are often a summary of a robust evidence base, and often, depending on the cadence of updates, really provide an up-to-date evidence base for a particular disease or condition. So they really can help to inform a plan coverage decision, especially for emerging technologies and treatments. Referring to those clinical guidelines can also help to ensure that, and again, at the end of the day, this is about patients and the care and treatment that they're getting. And so it can help to ensure that patients are receiving care and treatment that is covered by the plan and that's aligned with an up-to-date evidence base. But there are limitations too. Guidelines, medical society guidelines, are often agnostic as to whether particular formulations of medications or particular types or brands of devices should be preferred on a plan's formulary. So in other words, guidelines aren't rank ordering brands or different types of devices or services against one another. Payers, on the other hand, may have really good reason not to cover every available product because, again, they need to be able to control costs in order to keep premiums reasonable. So that's the balance there. And clinical guidelines typically do not include an assessment, and this is, big asterisks. I think some of them are starting to, but typically do not include a robust assessment of the relative cost and value of each intervention. So I gave you a rapid fire overview of clinical guidelines and how they inform plan coverage decisions. And now we're gonna turn to our expert panel and we're gonna dive deep. All right. So I'm going to start with you, Dr. Osagi, and I'm going to start with the ADA Standards of Care in Diabetes. So I'm wondering if you can start out by just describing in brief what these guidelines are, how they're developed, and how they're intended to be used by both clinicians and health insurers.
I appreciate that, and thank you for the opportunity to be a part of this and such an important conversation as well, and one that aligns with our priorities at ADA as well to ensure that our standards become routine practice. So this really fits into a lot of what we're trying to do. So the ADA every year for the past 35 years, we've had a history of being the trusted source as it relates to clinical guidelines in diabetes and diabetes management. So every year, there's a committee that's called the Professional Practice Committee that's selected by ADA in a very rigorous process. The ADA board is actually involved in vetting who is on this committee, and we review conflict of interest, all of the formalities to ensure that whoever is having a seat on the table, they are representing the best interests of people living with diabetes. So that the process starts with the professional practice committee meeting together, and then there are subgroups or subcommittees across specific chapters. I'm going to zoom in a little bit on the diabetes technology because I know we'll spend some more time there. And my colleagues will actually put in the chat the chapter specifically focused on diabetes technology, chapter 7 of our guidelines. Now, there's a technology subgroup. What they do is they review the last 12 months, what has changed in the diabetes technology space as relates to new evidence. So we're typically looking for 4 types of evidence: a robust clinical trial, or what we call prospective study, or we're looking at other kinds of study or cross-sectional studies. And then if none of those are available, we're relying on expert opinion. But the standards also grade the strength of the evidence as well. And based on the strength of the evidence, based on what the previous research has been, the subcommittee makes recommendations to the broader committee to think about what changes do we want to have. So in the last year, for example, in 2025, there are 32 broad recommendations as it relates to technology. A good number of them continuous glucose monitors, which we'll talk some more about. 4 of those recommendations were new recommendations based on new robust research in the field in the last year. 8 of them were modified recommendations. So the strength of the evidence changed in some cases, or the who should be a part of this or who should be covered in their non-insurance coverage now, more of coverage in terms of recommendation, also broadened in terms of some of the what we put out. So there's the whole process. It's a very comprehensive process. I've had the pleasure of being a part of it now for 3 years, and I can speak to just how much goes into ensuring that whatever makes it as a recommendation, there's a strong evidence supporting that. And sometimes that evidence also includes the cost benefits. Now, you won't see that specifically in the recommendation, but those are all factors that goes into, when the ADA puts a recommendation out, what it is, why we feel strongly about it, and more importantly, how implementing those recommendations will make a difference in lives of people living with diabetes. So that's a bit of the process. Next month, at this time next month, the 2026 standards will be out somewhere mid December or early December. And those will also include some modified recommendations, some new recommendations, and then that process sort of repeats every year. Rarely, if there's a late breaking or a very significant change in the evidence, we'll go back and do a review, and then we can introduce some updates mid-year. But for most times, December, it's when you can expect new set of guidelines, new recommendations, and it's something the ADA has done for the past 35 years.
Thank you for that very clear recitation of what sounds like a very intensive process. And I appreciate you going into detail too, that it's not just a sort of recitation or description of evidence that's out there, but a very intentional weighing of different evidence and assigning of different strengths. So that's really helpful. That gives us sort of a foundation of what goes into the standards of care. And I'm wondering, for diabetes, I think, in particularly the diabetes technology space, and thank you for referencing and referring us to your chapter 7. We love it. We read it all the time. Can you talk a little bit about CGMs, just as an example of a technology that is pretty dynamic and that has gone through some changes in terms of the evidence base, in terms of people with diabetes who could benefit from a CGM, and how the standards of care sort of evolved to change with the changing evidence standard for CGMs?
No, happy to. And so for friends that might not understand what or not be familiar with what a CGM is, it's a small device that most times you can wear on the body that gives you and I'm gonna explain this as lay as possible, that gives a sense on what the blood glucose level is. Now, it's not measuring blood glucose level specifically, it's measuring what's called interstitial glucose, but it can be used to give a sense on what the glucose level is. So it's been a major breakthrough. It is a major breakthrough in managing diabetes because now we can move away from having to do finger pricks that used to be the way to have a sense on what's glucose level is. And in diabetes, it's a very critical component of management because all of what we're trying to do in diabetes is ensure that the glucose level, it's within what we call the normal range, or it's in the normal range for an extended period of time, what we call time in range. So having a CGM or continuous glucose monitors is it's an easier way that has been shown to create a lot of short-term and long-term benefits, because now with this device, it's beyond the information. It's also sort of the insights, the data insights, and all of the actions that can happen with that data insights to truly help an individual living with diabetes. Now, the standards, ADA standards around CGM has evolved significantly. Diabetes, the very common types of diabetes is type 2 diabetes, type 1 diabetes, gestational diabetes, and a host of others too. But most times when we talk about diabetes broadly, we're thinking type 2 diabetes, rightfully so, because that's where you have a large proportion of people in the society with type 2 diabetes. But our CGM standards for ADA CGM standards sort of started from this should be offered to people with type 1 diabetes, and actually not even just anyone with type 1 diabetes. There was a little bit of a context there of offered to people with type 1 diabetes that can use these devices and have demonstrated that they can handle those devices well. So I'm talking 8 years ago, 9 years ago, that was the language, was specifically just around type 1, and there was added sort of context on the individual needs to be very comfortable with using it, need to understand this. So there were all of those caveats there. It's since evolved to the devices have been improved, and there's a lot more comforts in using the devices. So now, well, anyone with type 1 diabetes should have access to a CGM or continuous glucose monitors. And then it evolved to a place where, well, new research, new evidence from different device companies and different researchers all across the country started to show that, well, even for people with type 2 diabetes that are on insulin, they can also benefit from CGM, and ADA updated the recommendations with that research guidance to show, well, it's not just type 1 diabetes alone. If you have type 2 diabetes and you're on insulin, we're seeing the evidence that you can benefit from a CGM. So the standard was updated to reflect that. And now, most recently, the ADA standards now reflect where the current science is or where the field is, which is even if you're a patient with diabetes that is not on insulin, with type 2 diabetes not on insulin, there's significant benefit from using a CGM in terms of short-term outcomes, long-term outcomes. So now our standards say, irrespective of insulin, people, children, adults with type 1 diabetes, type 2 diabetes, should be on the CGM or should be offered the CGM. So it sort of evolved from type 1 that understands technology and understands all that to any type 1 to insulin dependent to now not insulin using or not insulin dependent type 2. So now it's type 1 and type 2, you should have a CGM. There's tremendous benefit from it, and we want everyone to truly experience the potential power of it.
Thank you for that, Dr. Asagi. I think that really paints a very clear picture and a very specific example of how changing evidence for technology and changing technology itself kind of necessitates a need to continuously review evidence and adapt and evolve standards. So you've set us up well in terms of the what the ADA does in their review of evidence and the development of their guidelines. So I'm going to turn now to you, Heather, to give us a perspective from a sort of payer lens, building off of what Dr. Asagi has shared about the ADA standards of care and its purpose. Can you tell us a bit about how ACAP members make decisions about what services to cover, especially when it comes to diabetes care? For instance, do your members reference clinical guidelines like the ones put out by the ADA or other peer-reviewed evidence?
Absolutely. Thank you, Amy. And first off, I'm just really grateful to be part of today's webinar. I think we've got a really great topic and conversation here. So a little bit of background, ACAP represents not-for-profit, mission-driven safety net health plans. So what that means is safety net health plans are plans that are focused particularly in the Medicaid space, but some that are also in the dual space or in the ACA commercial coverage market. And they really use that Medicaid focus on care management and bringing that to all of their other lines of business. So they're really coming at this from a holistic angle. I also think it's really notable that our members tend to score an average of almost 9 percentiles higher on the quality rating score, diabetes related scores. So that's a little bit about ACAP. And, I also am, passionate about this as the child of a type 1 diabetic. Hi, Dad, if you're watching, I think he might be. Getting back to your question, our members do reference a variety of clinical guidelines and evidence-based practices as they make their coverage decisions. So this does include the ADA standards of care, as well as using a variety of other platforms like Interqual. But they also include clinical studies. They look at data based on case management, evidence-based studies from groups like PCORI and ICOR, randomized clinical trials, research publications, you name it. So there's really a lot that is taken into account for these decisions. But I do want to note that it's not quite that simple and that there are challenges that arise from using evidence-based studies, which do differ from clinical guidance. And so while they can help understand maybe what is possible and what is effective, adapting them to local context can actually be really difficult. So For example, they might provide insight into available interventions, but there's not always a direct one-to-one application for practice. A plan can use this information, but they also need to consider their population, the performance data of any given intervention, stakeholder buy-in, all of these things when they're setting up their coverage guidelines and their benefit design. So, plans do also tend to cover disease management programs that are based in clinical guidelines. They use evidence-based guidelines to develop formularies. That's done in oversight with pharmacists who stay on top of the latest standards, in order to really ensure that there is access to appropriate and evidence-based medication. So ultimately, issuers use this information in a variety of ways, and that's both for coverage decisions, but also for innovation, supplemental benefits, care management. All of these things I'm happy to get more into later on.
Thank you so much for that, Heather. I mean, it sounds like what you're saying is that the clinical guidelines developed by the ADA, which we just heard about, are clinical guidelines for a whole host of other conditions, inform plan coverage policy and decisions, but are part of a sort of larger package of evidence and considerations. So I think that's helpful for us to know. In other words, we wouldn't copy paste the ADA standard of care as I was going to say a name, but I'm not going to, as a major insurer's standard of care. And so that's helpful. And I'm gonna ask you like a slightly more narrow question. And you'll probably hear like an audible groan from everybody out there when I say the words prior authorization, because it is something out there that can be quite a challenge. So if we're talking about prior authorization in particular, so not just kind of what to cover in general, but what to limit and the circumstances under which a particular service should be limited. Can you tell us a little bit about how insurers, how your members would decide to use prior authorization, how that kind of goes with some of the considerations with the evidence base and the guidelines, particularly for diabetes care?
Yeah, that's a great question, Amy. And let's take a step back a little bit as answer this. So as I mentioned before, our member plans and issuers in general, frankly, offer a variety of different benefits for diabetes care, as you were talking about. So some of these may require prior authorization or step therapy, but not all. And there's really quite a lot that goes into plan design and making decisions around cost sharing, utilization of particular benefits. So quite a number of our member plans, for example, offer $0 insulin copays as a signature benefit. And they do this because they're looking at the patient holistically and focusing on preventing serious health consequences, thinking about things like medication adherence. So this also translates to issuers, including not just those traditional benefits, but also investments in prevention, in self-management programs. They have incentive programs to encourage members to get their diabetes-related screenings in order to better manage that care, prevent worse outcomes, and contain those related costs. So in the context of prior authorization, I actually want to share an example of one of our member plans that has a kind of unique and innovative product design that prevents in the form of a diabetes-specific qualified health plan offered on the exchanges. This is a diabetes plan. So they offer this both as a silver and gold level QHP, and it has $0 copays for diabetic medical services, including your A1C screenings, retinopathy eye screening, kidney disease screening, diabetes self-management education, nutritional counseling, diabetic foot care, you name it. This also includes $0 drugs, including all types of insulin, as well as $0 glucose meters, test strips, diabetes supplies. And notably, they do also offer $0 CGMs, but that is the only component of the plan that requires prior authorization. So looking at it globally, in many cases, there is, how do they look at prior authorization? So in many cases, there is some form of utilization management for continuous glucose monitors. It usually does require a diagnosis of diabetes that requires insulin. In some other cases, it is based on A1C levels, glycemic controls, or even hypoglycemic unawareness. These tend to be fairly straightforward clinical requirements that are based on those clinical guidelines rather than, hoops to jump through for the sake of jumping through them. And, I think it's important to think about the fact that prior authorization is also a way of being diligent with members' money and ensuring that services are not being overutilized, especially given all the rate pressures we've been seeing lately and concerns around fraud, waste, and abuse. So just to close this out, for example, the same diabetes care plan that I'm talking about actually considered whether or not to have $0 CGMs for covered for prediabetes. And ultimately, they looked at the evidence and there wasn't enough of a clinical benefit there to warrant that coverage. So the prior authorization is really helping ensure that the right benefits are provided in the right circumstances to the right patients.
Thank you so much for that, Heather. And I will say I appreciate you sort of taking a broad lens because I think it sort of opens up the plan coverage decisions to not only be about how do you design a plan to limit access to particular service in order to save money or be cost effective. But it could also be that it is cost effective to provide access to services, to zero out deductibles or cost sharing. And I think that's sort of the example you're giving with the diabetes specific individual market plan. So I appreciate you sort of laying out that there are actually two stories there in terms of cost saving and cost effectiveness. All right, we've set the stage for you, Kyle. We've heard about the guidelines in the evidence base. We've heard from Heather about how health plans are using the guidelines and evidence base to inform coverage policies. So and you've got the hefty task. Why does it matter, right? Why does this matter for someone with insulin requiring diabetes? How do all of these decisions translate into the experience that someone will have in accessing the care that they need?
Oh, thank you, Amy. And it's great to be here today. I'm glad we're having this conversation. For those of us that rely on insulin for management of diabetes, these standards of care are and the coverage policies are definitely not abstract, and can sort of determine whether someone can live safely day to day or with diabetes or it can determine whether we can live safely day to day with diabetes. I mean, so much is Heather sort of touched on all the things and the various therapies that we rely on. So much is needed to manage type 1, like insulin, CGMs, insulin pumps, all the supplies needed to use these devices, test strips, glucagon, and access to these things can make the difference between stability and crisis. I know the ADA sets the gold standard of care, but then payers get to decide whether that standard is accessible to patients. And I know for myself, I remember when I was first diagnosed with type 1 diabetes, I was so nervous about just being able to access the things I needed. Getting approved is one thing, but then you have to worry about delays with if you're going through a durable medical equipment supplier, and all of the delays that can come about when attempting to even get a prescription filled. It's just really unnerving. And I think related to the policies, one of the things that's really complicated about it is many people just don't even understand how the system works. So I know at Kyla Cares, we spend an exorbitant amount of time helping people with health insurance navigation, making sure that they have the proper policy needed to access all the things they might need to manage. and that's many people are have the wrong policy basically, and their out-of-pocket expenses are exorbitant as a result of it, and just them not understanding that there could be a better policy to meet the needs that they may be facing. I also think it's important to understand that living with this disease, it it's so difficult, especially for marginalized communities, because it requires time. I know I personally spend a lot of time on the phone with my insurance company, spend a lot of time ordering supplies, the time needed to even educate yourself on how to properly manage diabetes. And then there's the financial cost that comes along with living with a chronic condition. And for families that are already strapped financially, this can really exacerbate like financial crisis in the lives of some of these families. And all of this leads to a lot of mental strain, which also impedes one's ability to properly engage with management and to engage with making all of those calls and advocating for yourself. So, and I know Heather also touched on the prior authorizations. We're finding a lot of provider frustration as well, as a result of many of the prior authorizations that are needed, and also having to help patients deal with appeals for denials that they may receive. And that sort of like can lead to providers not prescribing certain therapies for patients, which creates another access problem. So, and and it also leads to just patients being frustrated with physicians, physicians feeling like patients aren't they I hate to use words like compliance, but patients aren't complying with therapies that are being prescribed. But it's sort of like it's all impacting the patient's ability to properly engage with the management of type 1 diabetes.
So thank you for that, Kyle. I think that you've really gone deep in terms of the all of the different elements that somebody would has to navigate on a daily basis, and sort of advocating for themselves with their provider, with their health plan, and the sort of the time, but the sort of emotional expense of that as well. I'm going to ask you a follow-up, and I'm actually just to put Dr. Asagi and Heather on notice too, because I'm going to ask you guys the same question. We're getting lots of questions in the Q&A, and I want to make sure we have lots of time. So I'm going to sort of intersperse those questions as we go. But this is related to what you were just talking about, Kyle. So I think now is as good a time as ever. So can you talk a little bit about you talked about prior authorization there at the end, and one thing that we've certainly seen and heard from folks, and I think that you're alluding to as well, is that one way that prior authorization is used is to incentivize coverage of particular types of insulin, particular devices, instead of others, right? And so, one person has written in that this type of coverage policy actually sometimes results in people switching from one device that they've been on, or one type of insulin that they've been on, to another device or another type of insulin, because the coverage policy of the plan has switched, or maybe they've switched to a different insurance plan. But at the end of the day, like, the patient is switching on an insulin or a device, or from an insulin or device that's been working well to something else because of a plan policy. And I'm wondering if you can speak to that. Is that something that you hear about at Killelea Cares? Is that something that you see happening in the prior authorization space? Is that something that worries you, or that people can usually sort of roll with? Like, what are your thoughts about that?
Most definitely. I was just on the phone with one of our team members at Kyla Cares, who also lives with type 1 diabetes, and she was dealing with that exact same issue. And she just shared that she switched policies 2 months ago and has not been able to get insulin. So finally got approval for the insulin today and was told by the pharmacy that it's in the process of being filled. But yes, that is an issue that continuously comes up. And it just creates a lot of, like I said, a lot of frustration all around when providers are prescribing certain therapies and being told, well, that therapy we're not covering that therapy. You should prescribe a different therapy, which may lead to a different result. So it's like we're telling providers who are really, and many of which who are in tune with like the needs of their patients, that certain therapies that they're providing or certain therapies that they're prescribing won't be covered. And it creates a lot of frustration. I remember I love antidotes, and I remember when I was diagnosed and was discharged from the hospital. I immediately ran into a prior authorization issue where the insulin that I was prescribed wasn't covered. So I was just released from the emergency room, had no idea how to get in touch with my doctor because I just met this man and didn't have any of his information. I was not in tune with all the things I needed to know about diabetes management at the time, and had to, right after getting out of the hospital, call the emergency room and try and find someone that can give me a new prescription for what the insurance company was saying they would provide or would cover. So, yeah, we work with a number of hospital systems around the country now, and this is something that is constantly coming up. Just all of the prior authorizations that are being required, even for things outside of technologies, things
Mhm.
like glucose test strips is something that keeps coming up because many patients aren't tapped into the technology. We're trying to encourage more patients, especially from marginalized community, to utilize technology in management. But it's something we're working on. But as we run into these issues, it definitely makes it harder to encourage patients to engage.
Mhm. Mhm. Thank you for that, Kyle. And I'm going to turn to you, Heather, and I'm going to frame this in like a slightly different way. Certainly want your take on why a plan might change their offerings, especially in sort of a competitive class. If we've got multiple different, insulin available, we got multiple different CGM devices or AIDs, like why might a plan change from year to year, or even sometimes mid-year, what they're offering? And then, I mean, I imagine too that there are some plan sort of policies that help mitigate harm to patients during those changes too. So anything you can kind of lift up about that. But why might a plan decide to do that, to change what they're offering?
Yeah, it's a great question. And sometimes changes are based on, evidence and clinical guidelines that are being updated. And a lot of this, is unfortunately, and is no surprise to anybody, a lot of these constraints come from financial pressures. And it's, when you're looking at just the basics of risk pooling, the basics of insurance, that we have to take into account all of the variety of different costs. And that continues to add up. And if you have, unconstrained cost growth, what ends up happening is your premiums go up. And then you have only sicker, people who are sick and who really need insurance coverage are willing to pay those higher premiums. And then they go up again because that risk pool change has led to more sick individuals. And so, we really are also working to try to keep costs down. And it is, a balance trying to manage care appropriately and provide all of the services that people need while also at the same time paying attention to costs. And we've seen some really amazing innovation in the past few years, and we've seen a lot of blockbuster drugs. So, stepping out of the diabetes space for a second, some of these drugs do amazing things for people, but also with enormous costs. And we saw this with hepatitis C drugs, which came on the market mid-year. And we're seeing this now with gene and cell therapies, GLP-1s, but that price tag has to get picked up somewhere, and it keeps putting ever increasing pressures on the premium. So what we saw with those hepatitis C drugs when they came on the market mid-year is that all of a sudden a whole bunch of plans almost went out of business. They could not afford to keep that in the market when, especially when these things happen mid-year. Um, rates need to be actuarially sound in order to, continue to operate. And that's really a fine balance. And so we're seeing this now with GLP-1s, and there is a lot of GLP-1 coverage for diabetes. But when I look at plan filings from this past year for this upcoming year for 2026, many plans are actually specifically referencing the cost of GLP-1s as reason for their premiums increasing. So, there's a lot to factor in there, and, unfortunately, cost is part of that.
Thank you, Heather. I appreciate that, and I appreciate you sort of naming the elephant in the room. That's important. And Dr. Asagi, just to give all three of our panelists a chance to kind of weigh in on this question of what do you think of the challenge of sort of the plan changes in terms of the types of devices or insulin or other services they offer, whether that's mid-year, year to year, and patients ultimately having to switch what they've been on?
Yeah, no, it's a great question, and I think that one of the um, another angle to this, to sort of add to the dynamic of our conversation, is how quickly do we match and sort of educate the providers on those changes and those switches. So, and where I'm going with this thought is some of my research has been focused on understanding the impact of insurance on equity and access. And one of the things we found in that research study, published this in Diabetes Technology and Therapeutics Journal, it's the insurance can be a critical route for buyers. And what I mean by that is even when that insurance coverage now starts to cover that device or that technology, some of the previous model of, well, we don't cover this, or you have to go through these 4 or 5 steps, that get lost a bit in translation, even if that change happens. So I think one of the things I'm very passionate about is, as we're updating the coverage and as we're doing a lot of the recalibration, I think it's really important to educate the patients on that. More importantly, it's also important to also educate the providers on what is changing and really giving them a chance to understand that, because I hear from colleagues that, well, we don't offer CGM because this insurance doesn't cover that, or because that insurance doesn't cover it. Now, that might have changed mid-year, or that might have changed a year ago, but because it wasn't covered a year ago, that still impacts patients today, or that still impacts patients right now. So I think it's that sense on, as these changes are happening, to think about the impact on people, on the impact on providers that might not be as aware of some of those changes as well. And one of the things that we're trying to do here at ADA is to empower patients to be advocates in this journey as well. So empower patients to understand what the options are, to be able to speak to the provider about that, the whole concept of shared decision making, and also to be advocates with the insurance company as well. How do you understand, oh, this is what's best for me medically, and to have that conversation with not just the provider, but a lot of insurance companies welcome that, for you to pick up the phone and actually talk to someone there on why is this not being covered? This is how I'll benefit from that. I think there's a lot we can learn from that self-advocacy and pushing for that. So yeah, that's another aspect on this. It's the frequency of those changes and communicating those changes back to the beneficiaries, both providers and patients. I think that is a critical part that gets missed sometimes.
I really appreciate you raising that because I think, that's important. You could have any sort of evidence change and, your ADA standard of care could change, but if folks are unaware, it's not really getting implemented out there in the field. So thank you for making that point. You've also raised, and I'm going to ask you the same question too, Kyle. I like to prepare people ahead of time. So we got, first of all, I will say, Kyle, you're getting a lot of love in the chat. And so this is like a sort of segue, and people are appreciative that you're bringing like a real voice and a real lens to what are often, fairly wonky, nerdy, insurance coverage conversations. So my question, this is an odd segue, but my question for you, Dr. Azagi, is that in the development of the ADA standard of care, how are our patient voices and people with lived experiences voices incorporated into those standards? Is there something formal? Does that happen? What does that look like?
It's a great question. I will start first from the board, the ADA board, because the ADA board has the ultimate responsibility for the approval and the development of the standards. The first piece is on the ADA board, there are 4 people that have board seats that actually live with diabetes. And then most of them with type 1 diabetes. So there are 4 board members that are very passionate about this conversation and very passionate about advocacy and being a voice for people living with diabetes. Our board meetings, it's sort of very vocal with a lot of the board members expressing their views as people living with diabetes on, what's that process here. And the committee level as well, we've been very fortunate to also work with people that wear both lanes as a researcher or a provider, and also living with type 1 or caring for someone with type 1 or being involved in that process as well. And then there are some of the subcommittees that I referenced that also includes professionals and that are part of that live with type 1 diabetes or type 2 diabetes that are part of helping in that decision making or giving feedback there. Now, when the standards are released every year, there is a public comment period that is open, and everyone is welcome. Once the 2026 standards are released on the ADA website, diabetes.org, particularly in the main page, there's an option to be able to add a comment on any of these standards and sort of share your own reflection or your perception on that. And I should add that there's a patient version of the ADA standards of care. So there's the hefty documents with 350 plus pages, 600 recommendations. We have a simplified version that is patient facing and just for people living with diabetes to understand this in lay terms. And that's also on our website. But we welcome comments, we welcome feedback, we welcome the perspectives of people living with diabetes annually. Through the public comment period, we take all of that into account in the next round of developing the standards. And then the last part I'll add is it's a lot of the work we do now is centered on taking that to practice and, having opportunities like this where we get to speak about that. We also work with national associations in the primary care space and the specialty space. We work with other patient advocacy associations too that have a strong voice and can help us in bringing those patient voices into the execution, implementation, and also the development of the standard. So, Amy, I think there are multiple levers and multiple avenues, first from our board to the committee to sort of different advisory groups the ADA host that patients can be a part of, and then everyone has a role to play.
Thank you for that, Dr. Asagi. Kyle, anything to add to that in terms of where you see opportunities for people with lived experience to have a role to play in both the clinical standard conversation and the plan coverage conversation?
Yeah, most definitely. I would encourage people who have time to write into their lawmakers and to their state health departments, because what we are finding is that many there, and I know this depends, this varies state by state, but many states are really lax with relation to how often formularies are allowed to change. And to Dr. Sagi's point about providers being educated on these changes, especially in public hospitals. I mean, the cases that many of these physicians are dealing with are complicated, they're tedious, and they also have really intense caseloads. So there's not a lot of time, even on the side of the providers, to sift through the dense information that's being distributed by like insurance companies and Medicaid, especially Medicaid and Medicare. So it just makes it really difficult to keep up. So I think if there was some sort of standard with how often these formularies were allowed to change, that would definitely help with um, just keeping people up to speed with what's covered and preventing some of like the backlog and with like prior authorizations and all the challenges that providers and patients are facing.
Thank you for that, Kyle. And I'm looking at the time, so I am going to have Heather be our last respondent on this same topic, but I will just take like prerogative for a moment, and you could respond broadly or to this specific piece, Heather. It's totally up to you. But as this conversation progressed, I was remembering that we did actually have a policy change for a segment of the market starting actually in 2026 that requires plans to have, and it's the individual market and small groups, so not every plan, but not nothing, to have a one patient representative on their pharmacy and therapeutics committee. So that's the committee that a plan would have that makes decisions about what goes on the formulary and what doesn't go on the formulary. That's new. I think that was asked for by many patient advocacy groups. It is sort of one specific mechanism. Again, starts in 2026. Many of you are on the call now, so look to see what individual market and small group plans are in your area. Join their P&T committee. But Heather, what do you think of that? And are there other mechanisms like that that kind of give patients a voice in these decisions?
Yeah, it's a great question. I mean, I think that what the previous two panelists have said is, spot on around engaging. I actually want to answer this from a slightly more global angle because I think we've sort of we really have covered that patient piece. I think absolutely that is an important role having patients as part of that pharmacy and formulary committee, but it also speaks to the challenges that we as issuers have of having different rules for each different line of business. As you were just saying, that applies for the individual market. We have different rules around covering GLP-1s, supplemental benefits, other things like that for each different line of business. And that's something that's really can be a challenge. And I think that there's some thought that can be had by policymakers around, a couple things. One other theme that I've seen in the chat here and talked about a little bit is, understanding what's in the formulary and those changes. And I think that it's really hard for issuers to make this, we make this information available, but it's not, CMS provides information in a standardized format. And so you don't always necessarily see those unique pieces or what's in the formulary. And I think there's some thought that can go into making it easier for patients to choose the right plan for them by having that information more available and accessible. That diabetes care plan that I mentioned at the beginning, they thought about putting those $0 benefits into all of their regular plans. And ultimately, they didn't because it gets hidden. When you list what your standard copay is, if it's $30, the fact that you have a $0 diabetes copay doesn't show up. And so I think that there's some opportunity for policymakers to be thinking about how do we make these things available to patients. And I think also, I'm going to close since I know we're at time by saying that I think there's also a lot of special supplemental benefits that you can get in places like Medicare that are really important and useful, non-medical benefits, food supports, home modifications, things like that, that can really be a benefit here too. And so I think that there's a lot for policymakers to be thinking about how to make these more available across all your lines of business. And I'm sorry I talked so long.
You are fine. No, I think that is a fantastic way to close this out. We have a fragmented healthcare system, and navigating all of these disparate rules is hard for payers, it's hard for providers, and it certainly is hard for people who actually need care. So I think that's a good note to leave on, and to be continued. We will continue this conversation, like I said, at our next webinar. I want to close this out here and just thank you so much to our speakers. I think this was just an incredibly rich conversation. So thanks for joining us. Thanks for all of you out there for listening today, for asking really good questions. And thanks to our funders at Helmsley Charitable Trust for making all of this possible. When you exit the webinar, you'll be asked to complete a survey. Please do it. I promise it won't take long. And we really use that information to help plan our future webinars. Watch this space, more to come. And thank you all again.